Today we are going to discuss about liver diseases. Let's begin. So, guys, firstly we have to understand what are the functions of liver. So, today we are going to discuss about liver disease versus psychiatry MCQs. Liver function is to detoxifies, metabolizes the nitrogenous waste and deactivate some pharmacological agents. It may deactivate some pharmacological agents and metabolizes the nitrogenous waste. And liver produces albumin, and liver produces the coagulation factors like factor second, factor fifth, factor 7 and factor 10. Liver is a major hub of venous traffic between lower body and right atrium portal tract. Okay, so hope regarding the liver function it's very much clear. Now we are going to discuss about cirrhosis. What is cirrhosis? Is a pathological state of the liver which is caused by chronic insult or by inflammation. This is mainly caused by chronic insult or inflammation. The pathological changes interferes with the ability of the liver to function properly, as well as the ability of blood to properly move through the portal tract. The first primary cause in America for liver cirrhosis is alcoholism. So guys, try to write in a comment box what other causes responsible for liver cirrhosis. Do you know the causes responsible for liver cirrhosis? So guys, today we are going to discuss about liver disease, and the most common cause is alcoholism. Cirrhosis is an irreversible and incurable. If cirrhosis of liver occurs, that means it is irreversible, never going to be reversed, or there is no cure for liver cirrhosis. The treatment therefore focus on reducing the symptoms. The symptoms which is produced by liver cirrhosis we have to treat symptomatically. Cirrhosis always increases risk of hepatocellular carcinoma, liver cancer. If somebody has liver cirrhosis, he is more prone towards hepatocellular cancer. A patient is more prone towards hepatocellular cancer. Now, let's see. I already explained the function of liver. So, liver produces albumin. If it impairs the albumin function, means low albumin production due to cirrhosis, it causes ascites and edema. Due to ascites and edema, the kidney thinks that there is low volume in body, that's why they start activates aldosterone. That's why in ascites and edema due to liver cirrhosis decrease in albumin, we treat with spironolactone. In spironolactone is a aldosterone antagonist. It acts on aldosterone, so it helps to reduce ascites and edema also. Yeah. And we have to be very much watchful regarding spontaneous bacterial peritonitis. Bacterial peritonitis, we have to do peritonitis like ceftriaxone or cefotaxime. Okay, good evening. And liver produces factors like 2, 5, 7 and 10. Due to liver cirrhosis, there is a deficiency of all these factors which causes bleeding and increase prothrombin time. That's why in this condition we have to treat with fresh frozen plasma, FFP we need to transfuse. Now, due to portal hypertension, we see portal hypertension due to liver cirrhosis, there is portal hypertension developed, and it causes splenomegaly, hemorrhoids due to inferior mesenteric vessels, rectal hemorrhoids. Treatment is by banding or spider angiomata on skin, and esophageal varices we have to treat with octreotide, or we can give beta blockers, or we use banding technique. Okay. Liver helps for detoxification. So due to liver cirrhosis, impaired function of detoxification. So here is hepatic encephalopathy, asterixis, and decreased drug metabolism. So we have to treat this condition by lactulose. So guys, I already explained the function of liver due to cirrhosis, what pathophysiology occurs, and how to treat. Now, this is a clear-cut case of ascites. It's visible. This is a ascites patient. Okay, now, serum albumin ascites gradient. Serum albumin ascites gradient. What happens here? How to calculate albumin in serum minus albumin in ascitic fluid. So we have to identify. There is two causes of ascites. First one is exudative, another is transudative. Transudative. In exudative causes includes high portal pressure. This would result in high hydrostatic pressure that force the fluid only out of the vein. So the veins are leaky due to high portal pressure and fluid is come out, not albumin. So what happens here? There is high serum albumin gradient, acetic albumin gradient. Why? Because in serum, let's see, in serum albumin is higher concentration, and in ascites only fluid is leak out due to portal hypertension. If we minus serum albumin minus serum acetic fluid, that's why the serum albumin acetic gradient is higher side. Where is transudation? The causes T starts from TB is infectious cause, so infection causes transudative sites, and cancers causes transudation. There are various unique causes for this, but the common results in both fluid and albumin leave the vein. In transudation, what happens from the vein? Fluid and albumin both leak. That's why what happen if we do serum albumin acetic gradient, albumin in serum low, but albumin in ascitic fluid is high. So low minus high value albumin gradient. Good evening. Low serum albumin gradient we find here. Okay. So hope in case of cirrhosis, high portal pressure, there will be a high serum albumin acetic gradient. Okay. Now, ascites. All patients with ascites should have periocentesis to sample the ascitic fluid and obtain a serum albumin gradient. As you know very well, I explained what was the role of serum albumin acetic gradient. We have to, this is exudative cause of ascites or this is transudative cause of ascites. And I already explained that if there is spontaneous bacterial peritonitis, you should be very careful because this is life threatening or death causing situation. So what happens in this? This is a lethal complication of ascites. The index of suspicion should be high for any patient with ascites that develop or presents with a fever or abdominal pain. Diagnosis by periocentesis or WBC analysis in acetic fluid. If more than 500 WBC, that means spontaneous bacterial peritonitis. And treatment by third generation cephalosporin, ceftriaxone. How to remember third generation cephalosporin? Taxim 3. May also transfuse with albumin, ICU admission and repeat periocentesis. Okay. Now, Ramesh, I will check is it 250 or 500. Okay. So chronic hepatitis, infectious disease. What is chronic hepatitis? This is an infectious viral disease which attacks the hepatocytes, resulting in chronic inflammation and fibrosis. As I explained, it is liver cirrhosis, it is an insult or chronic inflammation. Chronic hepatitis includes hepatitis B and C are the hepatovirus that causes chronic hepatitis. The chronic hepatitis, the risk factor includes IV drug users or tattoos, high risk sexual practices, needleistic injury, healthcare workers. So every healthcare worker should be vaccinated with hepatitis B. Even I already vaccinated with hepatitis B. So guys, those who are health worker, doctors, you should be vaccinated with hepatitis vaccine. It's very much necessary or useful also. Patient is usually asymptomatic. With chronic hepatitis B or C, patient is usually asymptomatic, no symptoms in chronic cases, but in acute cases some symptoms are there. So general signs of cirrhosis develop. History will be important. You have to ask history of patient. Maybe he had a history of tattoos, IV drug abuser, or needle-stick injury, or he's a healthcare worker, or high sexual practices, or multiple partners. Any patient with the signs of cirrhosis should be get hepatitis titers. If you find any patient with liver cirrhosis, go with hepatitis titer. In hepatitis B, we are going to see presence of hepatitis B surface antigen. In hepatitis C, we see presence of anti-HCV antibodies and positive viral load. And treatment, all hepatitis treat with interferon alpha. All means chronic hepatitis, not hepatitis A and E. Okay, my question I am going to ask not from liver cirrhosis here. What is the fulminant hepatitis in pregnancy? A fulminant hepatitis in pregnancy, which type of hepatitis is considered as a fulminant hepatitis in a pregnancy? 30 seconds in your hands. Try to write in a comment box. The hepatitis virus which is considered as fulminant in pregnancy are very much dangerous in pregnancy. A virus which is considered as fulminant in pregnancy, hepatitis virus. Option is A, B, C, D, E. Which one hepatitis? Bobby, it's C. Lashkar, it's C. Guys, hepatitis E virus. Yes, Sherman, you are absolutely right. Hepatitis E virus is considered as fulminant hepatitis, but it does not causes cirrhosis. Okay, this is very high yield MCQ which I asked. So hepatitis B treatment by adifovir, lamivudine, or hepatitis C treatment by ribavirin. Even I give a mnemonic in my hepatitis B lecture where I explain all the markers. If you want to watch hepatitis B lecture, you can write hepatitis B lecture by Dr. Hemant Sharma on YouTube. You find that lecture, and there I give some mnemonic also. Delete, it's adifovir, lamivudine, all. Okay, now primary sclerosing cholangitis. It's an idiopathic disorder of biliary ductal system, not of the liver. This primary sclerosing cholangitis causes liver cirrhosis, but this is a disorder of biliary ductal system. Result in cholestasis. What is cholestasis? Means impaired in bile secretion. There is obstruction or some impairment of bile secretion which causes inflammatory changes in the hepatocytes. This primary sclerosing cholangitis associated with inflammatory bowel disease. If patient with ulcerative colitis, he comes to OPD and he complains pruritus, jaundice and fatigue, you have to rule out primary sclerosing cholangitis in such patients. The symptoms include non-specific, sometimes fatigue, pruritus, jaundice are the most common. Malabsorption may be present. Other symptoms may be present. If you ordered a laboratory investigation, you see SGOT, PT or AST, ALT is normal, whereas elevated alkaline phosphate, elevated GGTP. Why there is elevation of alkaline phosphate? Please try to write in a comment box why secretion is impaired, why there is elevation of alkaline phosphate, why normal AST and ALT in primary sclerosing cholangitis. Is there any idea? Try to write in a comment box if you know the answer. Why there is normal SGOT and SGPT but raised in alkaline phosphate? Why? What was the reason behind it for increase in alkaline phosphate but AST, ALT or OTPT is normal? So I'm going to explain why. Due to bile impairment. When there is a bile impairment, we always see raised alkaline phosphate, or in case of metastasis, bone metastasis, we see raised alkaline phosphatase. And diagnosis, we have to advise here anti-mitochondrial antibodies titer, which is negative in primary sclerosing cholangitis, will differentiate it from PBC. It's primary biliary sclerosis, primary biliary cirrhosis. Okay. ERCP and transhepatic cholangiogram we are going to use for investigation. What is ERCP? ERCP is endoscopic retrograde cholangiopancreatography. We administered some tube inside esophagus, then it reaches towards the duodenum, then ampulla, and then we see this. And how to treat? Treatment is bile acid binding resins like cholestyramine, or definite exact treatment is liver transplant. So primary biliary sclerosis, now we are going to discuss about primary biliary sclerosis, an autoimmune inflammatory disorder, same like as primary sclerosing cholangitis, but some differences I'm going to explain you here. Biliary ductal system, not of the liver. This is a disorder of biliary ductal system, same as primary sclerosing cholangitis, same in primary biliary sclerosis. It results in cholestasis, same there also. So cholestasis means impairment of bile secretions, which causes inflammatory changes in the hepatocytes. Tends to be in middle-aged women who have other autoimmune disorders. In primary sclerosing cholangitis, we find in patient with inflammatory bowel diseases like ulcerative colitis and Crohn's disease. But this primary biliary sclerosis, we find a patient with autoimmune disease like autoimmune thyroiditis, or in case of Addison's disease, if patient with Addison's disease, he complains like pruritus, jaundice, fatigue. Always rule out primary biliary sclerosis in that patients. Patients may be usually asymptomatic. If we advise a laboratory, lab is same like normal AST, ALT means normal, SGOT, SGPT, but elevated alkaline phosphate and elevated GGTP. Why? I already explained, due to impairment in a bile, that's why there is alkaline phosphatase is raised. Diagnosis by anti-mitochondrial antibodies titer, here is positive, but primary sclerosing cholangitis there is negative. And how to differentiate from primary biliary cirrhosis? Do liver biopsy is a definitive investigation. In primary sclerosing, we do ERCP or transhepatic investigation, and treatment is by bile acid binding resins, same like their cholestyramine. Exact treatment is by liver transplant. So hope it's clear. Now hemochromatosis, even regarding hemochromatosis also I give a lecture on YouTube in detail, so you can write hemochromatosis lecture by Dr. Hemant, you can find there. In this video I am going to explain little bit small information regarding these diseases. Hemochromatosis, an inherited disorder of iron absorption, which resulting in a high serum iron levels. Iron deposits in the liver among the other tissues, leading to destruction of hepatocytes and cirrhosis. Means there is impairment of absorption of iron. It is inherited disorder. That's why the serum iron raised, serum ferritin raised. And what are the other symptoms? If it is iron deposit in a liver, it causes cirrhosis, whereas iron deposit in heart, it causes restrictive cardiomyopathy. Restrictive cardiomyopathy, most common causes infiltrative. It include amyloidosis, hemochromatosis, sarcoidosis, etc. I explain in cardiology segment. And if iron deposits in a joints, it causes arthralgia, painful joint movements, hyperpigmentation, bronze skin, or diabetes mellitus. If it deposits in pancreas, bronze diabetes we can say. And hypogonadism if iron deposits in gonads. Inquire family history of cirrhosis. If patient comes with all these symptoms, you ask the family history of cirrhosis or liver cancer or any liver problem with such patients. Hemochromatosis, we see impaired absorption of iron, but Wilson's disease, we see an inherited disorder of copper absorption and secretion. In Wilson disease, we find inherited disorder of copper absorption and secretion. Copper deposits in various tissues including liver, eye and brain. Copper is a toxic to the liver. This results in cirrhosis. General cirrhotic symptoms. Accumulation of coppers in the eye results in brown, green, Kaiser, flasher, ring. Even lot of time in exams they like to ask with a picture of Kaiser, flasher, ring. What is this? This is Wilson disease. Accumulation of copper in a brain results in various movement symptoms in basal ganglia when it accumulates and it produces psychosis. Cirrhosis of hepatocellular carcinoma with psychiatric symptoms should tip you off. Okay. If you sure to inquire into family history, particularly psychiatric history, family history of liver problems and liver cancer, same as hemochromatosis. In Wilson disease also there is accumulation of copper in brain, in eyes, in liver. Okay, and diagnosed by low serum ceruloplasmin level, high serum copper level, and liver biopsy is the most specific gold standard to rule out. And treatment is by penicillamine and deferoxamine in hemochromatosis treatment, deferoxamine and penicillamine in copper. Copper P, remember copper P, that's why penicillamine is an antidote. Okay. Now, this is a Kaiser Fleischer ring. You see this image giving on exam and you have to identify. So guys, see carefully. This is Kaiser Fleischer ring. Okay. Now, Alpha1 Antitrypsin deficiency. An inherited deficiency of protein Alpha1 Antitrypsin. This alpha-1 antitrypsin is a protein which responsible for inhibits uptake, which responsible for physiological degradation of certain tissues, think liver, lung. Deficiency leads to cirrhosis and pulmonary fibrosis. Okay, will usually present in first with emphysema. In emphysema, there is deficiency of alpha-1 antitrypsin. That's complaints here: shortness of breath, wheeze, dyspnea, refractory asthma, low LCU. Emphysema at a young age is highly suspicious of alpha-1 antitrypsin deficiency. Okay, if young patient comes with complaints of shortness of breath and dyspnea, wheezing, refractory asthma, so think about emphysema and diagnosed by alpha-1 antitrypsin titer that is low. Treatment is by enzyme replacement or symptomatic therapy, bronchodilators we can use. If patient is a smoker, advise not to smoke, and if he is not a smoker, advise in future also don't try to smoke. So this is a summary of all which we discussed. And finally, now some MCQs time. Hope you all guys will take a part. This is psychiatry MCQs continuation from yesterday's topic. Which one of the following selective serotonin reuptake inhibitor has the highest incidence of discontinuation symptoms? Paroxetine, citalopram, escitalopram, fluoxetine and sertraline. So guys, I hope you understand. It's visible in front of you, the screen. So try to answer which option is the best answer here. I'm waiting for your answers. Which one of the following selective serotonin reuptake inhibitor has the highest incidence of discontinuation of symptoms? Any comments? 30 seconds in your hands if you want. So no comments till now. So I am going to answer paroxetine. Paroxetine has a higher incidence of discontinuation symptoms. Okay. Next question. 57-year-old lady who is under a section 3 at a inpatient psychiatric hospital. She has stopped eating or drinking as she believes she is dead and does not require food anymore. Which syndrome is characterized by a person believing they are dead or non-existent? I already explained in my previous lecture so many times. Those who are watching my lectures, they know very well what kind of syndrome is it. So please try to answer in a comment box. This answer you know very well, I hope. So please try to answer. A patient feels he is the dead, he is not existing. What kind of syndrome? When they feel such feelings, in which syndrome? Single best answer, which one is here? So guys, try to write in a comment box. Yeah, paroxetine. Krishna Mohan and Bobby, you are absolutely right. This is Sharvan, you are writing Capgras syndrome. This is Cotard syndrome. He is dead, decomposed. And what is Capgras syndrome? I'm going to explain. When patient feels delusion of doubles, his relatives and his nons are replaced by someone else. Yes, Krishna Mohan, you are absolutely right. Capgras is a delusion of doubles. And COVID syndrome, Clarenbold syndrome, or erotomania is the same condition when female feels a celebrity fallen in love with her, and he's and Othello syndrome is a delusion of jealous, delusion of suspiciousness. A female or a male feels that his partner has some extramarital relationship with anybody, but exactly no proof or no such. Okay, now COVID syndrome is a sympathetic pregnancy. It affects father particularly during the first and third trimester of pregnancy, who suffers the somatic features of pregnancy. Okay, that is COVID syndrome. Now, 36-year-old patient presents with nausea, headache, and palpitation. He has had multiple previous admissions with such symptoms for the past 2 years. Each time no organic causes was found. What kind of disorder is this likely to represent? So what kind of disorder is it? When patient feel nausea, GIT symptoms, headache, neurological symptoms, palpitation, and had multiple previous admission with multiple symptoms, such symptoms from past 2 years. Each time every investigation is normal. So what kind of disorder is it? Even I explain in my lectures briefly about this. So what kind of disorder is it? Try to write in a comment box. Sharvan, writing hypochondriosis when patient feeling life-threatening diseases inside their body. This is not hypochondriosis. Hypochondriosis when patient feel he's had cancer or HIV/AIDS. That is hypochondriosis. Means life-threatening severe diseases. Was somebody writes the answer. Somatization, Krishna Mohan and Bobby, it's not hypochondrial. Somatization is the symptoms when GI symptom, nausea, headache, palpitation varies. So this is somatization syndrome. And in hypochondriosis, when patient feel he's suffering from cancer or maybe he has HIV/AIDS. Okay, such. So hope hypochondria means C means cancer or HIV. Somatization means only symptoms, multiple symptoms. Okay, pain. Now, 58-year-old lady presents to her GP, concerned her partner is being unfaithful. She appears very distressed by this, yet after further questioning does not appear to have any evidence to support her claims. Yet she is convinced she is right. What might this concern be a symptom of? Even this situation I already discussed in my previous lecture. So what kind of she is so much suspicious, she find that his partner has, yeah, one. This is a case of Othello syndrome. Yes, Othello's I explained. Capgras, you everybody knows delusion of doubles, and Grandiose delusion, everybody know I'm a god. Declarambol syndrome, erotomania means somebody celebrity in love, and here it's Othello syndrome when partner is feeling such. And okay, so Declarambol syndrome, also called erotomania, is a delusion belief that someone else is in love with patient. Charles Bonnet syndrome is experience of complex visual hallucination in patient with partial or severe blindness. Now, 21-year-old female admitted to the acute medical unit after a paracetamol overdose. She later admits to multiple episodes of impulsive self-harm and overdoses. She reports that her recent overdose was triggered by a fight with her dad and concerns that he will no longer want to see her. She describes long standing feelings of emptiness and does not like the way she looks. What is the most likely underlying personality disorder? Even personality disorder I take individually, I explain all personality disorder. So what kind of personality this lady is suffers from? Now I'm going to open chat, try to answer. Yeah, this is borderline personality disorder. Sherwan, you are absolutely right, brilliantly answered. This is an borderline personality. Bobby, you are also right. Okay, let's discuss every personality individually. Narcissistic personality, when person feel I'm a god, oh he is so beautiful, that is narcissistic, and never take any kind of he is always right, he feels. Paranoid personality, when patient is suspicious, same like Othello syndrome, or he is don't like to um, criticism, he don't want to take some criticism, he always remembers somebody criticize him, somebody teach him, he don't like. Okay, borderline is same. And dependent personality, when person is dependent towards mother or some friend, some boyfriend, he always depends on his decisions, everything. Avoidant personality disorder, avoidant is not able to take criticism, etc. So that is an avoidant personality. So I already explained here all personality disorder. So this is case of borderline personality. So guys, please watch my all lectures, that will help you to make your concepts very strong, which helps you to crack not only single exam but any exam, any corner of the world you are able to crack, your concept should be very much strong. Next question. 34-year-old ex-soldier with a history of post-traumatic stress disorder returns for review. He has had a course of eye movement desensitization and reprocessing therapy, which was not helpful, and is reluctant to try cognitive behavior therapy. Of the options listed, which medication may be useful in such patient where cognitive behavior therapy is not working? So which medication you are going to use? All options in front of you. You try to answer. Okay, I give you 30 seconds more. So guys, what is the best answer here? So which one is the best answer? Fluoxetine, Manusri, shower. Answer is Mirzapine. Okay, Bobby, you are right. Now, next question I'm going to ask. To hit on the chat. 88-year-old woman brought to her GP by her daughter because of new memory problems. She did not want to attend as she is worried about her memory and does not want to be diagnosed with dementia. She scores 12 out of 30 on mini mental state exam. Her memory is globally impaired with failure to retain new information as well as failure to remember important events from her life. Her daughter reports this has been the case for the past 2 months, and she was previously fine and had no cognitive concerns. Her daughter also reports she is struggling with sleep and her appetite has reduced significantly in this time. Although the patient does not think this is the case, what is the most likely cause of her memory impairment? Okay, so what is the most likely cause of her memory impairment? Okay, I'm going to close the chat and read options. Alzheimer's disease, chronic small vessel ischemia, Lewy body dementia, acute delirium, or depression. What do you think? What is the best cause? No comments. Alzheimer's disease, chronic small vessel ischemia, Lewy body dementia, acute delirium, or depression. Manasvi, this is depression. Shavan, Alzheimer's. Bobby, Lewy body dementia. Rahul, chronic small vessel ischemia. So the answer here is depression. Let's discuss. Severe depression can mimic dementia but gives a pattern of global memory loss rather than short-term memory loss. This is called pseudo-dementia. It can often be difficult to ascertain the cause of memory impairment of a single encounter, but there are three main causes to consider: a dementia process, acute delirium, depression, also called pseudodementia. Understand? Depression, also called pseudodementia. Why? Because there is no short-term memory loss. Here is in severe depression mimic dementia but pattern globally memory loss rather than short term. So global memory loss in pseudodementia, that is seen in depression. Okay. Next question. 65-year-old man with a background of chronic alcohol excess and previous Wernicke's encephalopathy is administered to the acute medical with behavior disturbance. He has not consumed alcohol in the past 2 years. Which of the following phenomena is likely to display on further assessment? That is confabulation, dysthymia, hydrophobia, Lilliputians, or preservation. Patient had a history of Wernicke's encephalopathy and from last to and now is present with behavior disturbance. So this is case of Krishna Mohan, confabulation. Yeah, absolutely right. Let's discuss. Confabulation in a patient with chronic alcoholism point towards Korsakoff syndrome. Korsakoff is characterized by confabulation and amnesia typically occurring in alcoholics. Yeah, Bobby, you are right. Secondary to chronic vitamin B1 thiamine deficiency, dysthymia refers to mild depression. Hydrophobia is the features of rabies. Lilliputians may be observed in delirium tremens. Preservation is repetitive speech patterns commonly seen after traumatic brain injury. Okay. Now, 21-year-old female being investigated for a personality disorder. She is found to be low in self-esteem and fearful of criticism or rejection, particularly in social situations. She reports struggling to make friends at work despite being desperate to be liked. She feels that her colleagues are much better at her job than her. She becomes very anxious every day on the way to work as she worries she will make a fool of herself. As a result, she struggles to hold down a job, often moving jobs regularly. She has had the same experience and relationships out of work as she does not feel good enough for anyone. What is most likely diagnosis? So guys, I already explained this also. Whether drinker thinks he is speaking truth or he's also known he's lying. Yeah. So answer here is, guys, which kind of personality disorder is this? She afraid to take criticism. This is dependent, paranoid, borderline, histrionic, or avoidant. Now I know you. Everybody knows the answer. Those it's avoidant. Manasvi, I think paranoid. I hope you not attend my lecture which I deliver. Krishna Mohan, it's she don't like to take criticism. So this is a case of avoidant personality, fear of low esteem, fearful of criticism or rejection. She is fear of taking criticism or rejection. So those who are writing paranoid, I'm going to explain. In paranoid personality, they don't like if somebody criticizes them. They always remember in their brain somebody criticized them. So they don't like. But in avoidant personality, they are afraid to take criticism, they are afraid to take rejection. But in paranoid personality, they are not afraid, they are really not afraid, they are suspicious, jealous. Hope it's clear. Yeah, so this is an avoidant personality disorder. And somebody writes dependent. Why dependent personality? Somebody is dependent on their each and every decision. Histrionic is attention seeker. Hope it's clear. This is avoidant personality. Okay, this is an avoidant personality. Now, an elderly patient in a nursing home is started on quetiapine due to persistent aggressive behavior that has not responded to non-pharmacological approaches. Which of the following adverse effects of antipsychotics increase the risk in elderly patient? So guys, all options in front of you. Atrial fibrillation, myocardial infarction, aspiration pneumonia, stroke or breast cancer. Quetiapine. Elderly patient, nursing home started quetiapine, persistent aggressive behavior that has not responded to pharmacological therapy. What adverse effect with antipsychotics? Manas B, Rahul, it's E. So answer here is stroke. Antipsychotics in elderly increase risk of stroke. Okay. So guys, I already finished with today MCQs and some liver disorders. Hope you like this video. So I'm going to ask some questions with slides now. Without slides, you have to answer in a comment box. In myasthenia gravis, we use which drug for diagnosis? Diagnosis of myasthenia gravis, we use the drug, name of the drug which we used for diagnosis of myasthenia gravis. The drug which helps to diagnosis of myasthenia gravis. 30 seconds in your hands if you want. Botulinum toxin, no. Adrophonium. Remember adrophonium. The drug of choice in myasthenia gravis is drug of choice in myasthenia gravis. The drug of choice in myasthenia gravis is adrophonium. For investigation we use. What happens? Patient comes in your OPD when you perform Pfizer statement, Rahul, it's absolutely right. What happens? Patient comes in your OPD and he complains when he like to walk, he feels very dull, lazy. When he perform activity, when you give adrophonium, his activities increases. This is short acting. Okay. So next question I'm going to ask. In atrial fibrillation, what is the drug of choice in atrial fibrillation? What is the first drug of choice? What is second drug of choice? What is third drug of choice in atrial fibrillation? When there is a atrial fibrillation, what is the drug of choice in atrial fibrillation? I am waiting for your answer. is there. Even cardiology section I already finished. So hope you know the answer. In atrial fibrillation, drug of choice: Bobby, Amiodarone, Rahul, beta blocker, Nasvi, adenosine. Okay, so Rahul, you are absolutely right. Beta blockers is the first drug of choice in atrial fibrillation. We can use digoxin also. Okay, and anticoagulants also in atrial fibrillation. Now I am going to ask a patient with benign prostate hyperplasia. What is the drug of choice in BPH? Even I explain the lecture in cardiology, beta blockers and alpha blockers. So, which beta blocker? Beta blocker like metoprolol you can use in prazosin, krishnamohan, tamsulosin. You know what? In BPH, we can use the drugs. Amiodarone is a second drug of choice, Bobby, not the first drug of choice we are going to use for treatment of atrial fibrillation. You are right, but not this is not a first drug of choice. Okay, beta blockers are the first drug of choice. You can use digoxin also and amiodarone also. So name the drugs which causes gynecomastia. No, I don't have any app. Name the drug which causes gynecomastia. The drugs which causes gynecomastia. Spironolactone, yes, it causes gynecomastia. What other drugs causes gynecomastia? Cimetidine. What else? What other drugs causes gynecomastia? Ketoconazole, spironolactone, steroids, digoxin. Absolutely right. You to remember DISCO, DISCO, D for digoxin, I for isoniazide, S for spironolactone, C for cimetidine, O for estrogen, and anabolic steroids causes. Okay, so DISCO causes gynecomastia. The drugs which causes SLE, systemic lupus erythematosus, is caused by which drugs? Name the drug which causes SLE. The drugs which causes SLE. Name the drugs which causes SLE. Systemic lupus erythematosus is caused by which drug? Drug induced SLE, I hope you guys all know sulfonamides, INH, yes. Any more comments? Sure one. Remember SHIP, SHIP, SHIP. S for sulfonamide, H for hydralazine, which we used for treatment of, hydralazine. Rahul, absolutely right. I is isoniazide, anti-tubercular drug. P is procainamide. So these drugs causes no problem. Remember SHIP from today. SLE drug induced is SHIP. S for sulfonamide, H for hydralazine, I for isoniazide, P for procainamide. Okay, I hope it's clear. Now, what is the antidote of paracetamol poisoning? The antidote of paracetamol poisoning is, what is the antidote of paracetamol poisoning? $30 in your hands. NAC, N-acetylcysteine, everybody knows. If patient comes in your OPD and he tells you 15 minutes back patient take 100 paracetamol tablets. 15 minutes back 100 paracetamol tablet he take with water. So how to treat? if in your OPD you are emergency doctor, DM emergency medicine, and patient enters, he already take 100 paracetamol tablets 15 minutes back, what is your next step? No gastric lavage, go give him activated charcoal. Activated charcoal, no dialysis, no gastric lavage, activated charcoal. If less than 1 hour, give activated charcoal. Okay, now same patient, activated charcoal is the best answer. If less than 1 hour, paracetamol intake, activated charcoal. Next, another patient comes next day, he take 75 paracetamol tablets and he enters in your OPD after 8 hours. After 8 hours of taking 75 paracetamol tablets, what is your treatment? How to treat this patient? If patient enters in your OPD, he gives you a history 8 hours back, he takes 75 paracetamol tablets. So how to treat? Manasvi, you are absolutely right. Give an acetylcysteine. In this condition, 4 hours till 15 hours, give an acetylcysteine. Below 1 hour, give activated charcoal. If more than 15 hours, that means patient is late. Okay. Symptomatic treatment and then liver transplant is indicated if is more than 15 hours admitted. Okay. So, what is the drug of choice in case of pregnancy induced hypertension? The drug of choice in pregnancy induced hypertension. What is the drug of choice in pregnancy induced hypertension? Labetalol. Yeah, everybody is right. Now it's labetalol. In severe hypertension, also labetalol. Earlier we say methyl dopa, but if methyl dopa and labetalol both are in option, go with labetalol. It's new change. Okay. Next question. A patient comes in your OPD and she is unconscious, and his mother give a history, she take 100 diazepam tablets. She took 100 diazepam tablets. So how to treat this patient? She is unconscious and history of 100 diazepam tablets. How to treat? How to treat this patient? Flumazanil. Shravan, you're absolutely right. We give the antidote of benzodiazepine, that is flumazanil. Okay. Flumazanil. Okay. Give with flumazanil. Next question. A patient comes in your OPD, his pulse is 0 and she is unconscious. How to treat? Patient is unconscious, pulse is 0. How to treat? All these topics I already explained in me. Yeah, CPR. So what is the first step in CPR? What is the first step in CPR? Start CPR. Any more comments in CPR? What is the first step in CPR? Anybody wants to answer? What is the first step in CPR? ECG. Okay. Any more comments? What is the first step in CPR? If somebody falls in, call the patient. Call the help. Ask help. ask help, ask help. No carotid pulse, no chest compression, nothing. In CPR, first step is help. What is second step in CPR? I already explained. First step, when you see somebody is collapsed, you ask help. Second step, scene safety. If he is in a road, you have to take the patient and make scene safety. Then chest compression, breathing, to respiratory breathing, 3 to 200 chest compression in a minute. Okay. Now we do a ECG with the defibrillator machine. When you put electrodes, you find there is asystole, zero pulse. Then what is your next step? We are performing chest compression. We intubate the patient already. We inject a cannula. Now what is your next step? With zero pulse, pulseless activity, then what is your next step? What is the next step? Yeah, chest compression we are continuing. We see zero pulse. What then? What next? Rahul, what next? What next step? Guys, give adrenaline. Bobby, it's true. We are already performing 30/2. Give adrenaline. Okay, give adrenaline. And what else? We give adrenaline after 2 3 5 minutes, 3 to 5 minutes. We administered again adrenaline. And what more drug we are going to administer in this patient? Adrenaline 2 times. And what next drug we can use for zero pulse? We can use atropine. We can use atropine. Okay. So guys, today I am going to finish here. Good night. That's all for today. And tomorrow I am going to discuss hematological MCQs, clinical based. And that's all for today. Thank you for watching my lectures. And if you like this video, please put like on it. And good night. Take rest. Yeah, atropine, adrenaline, give atropine. Okay, earlier we used vasopressin, but now no role of vasopressin. Okay, and if you want, you can watch my lecture on ACLS live classes, maybe 7 days back, delivered in cardiology section. So guys, thank you. Good night, good day. These are very high yield topics. That's all for today.